next option. Sometimes that also happens, it just gets stuck, even the 1.25 burr. Is Kirti around? Suppose the rota burr had not crossed the lesion, even the 1.25.
We've done in excess of 650, 700 rotos. It's never not crossed. Rota always crosses, it takes its time. Harish, you remember we did a rotational atherectomy at Hinduja once for a demonstration, and it was 72 minutes of rotational atherectomy time. It took us 1.5 hours to get across a lesion, which was 10 millimeters. So I think patience, that's all that it takes, but it eventually goes. Yeah.
Just for information that we did a re-angio on that man, he came with ACS. That stent is fine, he had a new lesion in the circumflex, which he had to rotate again.
The trick is to, at the end of, the company recommends that at the end of 5 minutes, that's 300 seconds of rotational time. That means the lesion being ablated, you need to change the burr and get a new burr because the burr is going to lose its abrasion plow. I have used it safely up to 12 to 13 minutes. But eventually, you do feel that you can hear the sound changing, and that's when you need to take off the wire and a burr and then go with a new wire and burr, and eventually it will happen.
Okay, thank you very much. This is a very interesting case, and 15 years follow-up study I have given it. Next slide, please. Patient presented 96 with acute anterior marketing infarction, and this 15 January, and they are postgraduate student at SSKM Hospital, and this patient risk of smoking, hypertension, hyperlipidemia, but patient not diabetes, and the history of bronchial asthma also. And within 6 hours, thrombolytic therapy streptokinase is given. After 12 hours, patient little symptomatic. We do the angio, shows the LAD from the origin 95% block, and subsequently that time we done the stenting done after pre-dilatation, Medtronic Victor stent. Next. So this patient used to come regularly 3 to 4 times in a year, so regular follow-up study, and ultimately 2007, you see, March, patient too much symptomatic for the particular chest pain. So we do the angiography that moment, shows the instant stenosis significantly by vector stent, and we plan for the revascularizations, and after pre-dilatation with a regular balloon, then the cutting balloon, then plan for the Cypher stent 3 into 23 millimeters, and excellent deployment and TIM3 flow result. Next, please. This angio shows, you see, Victor stent, very good resolution. It has a property of never always protect the side branch, and interluminal and narrowing, and lead loss of 0.32 of the bare stent. Next one. So therefore conventional balloon, then cutting balloon. Next. Yeah. This is finally cutting balloon. Yes, 2 to 3 times high pressure, so is given up to 15 atmospheric pressures. Next. Now you see, by the balloon and cutting balloon, diameter is increased, and then plan for the Cypher 3 into 23 millimeter diameter is placed from the ostium to the end of the restenosis. Next. So Cypher properly positioned from the ostium, it entirely covered the whole length of the instant area. Next. Then is deployed the Cypher at this 20 atmospheric pressures. Next. So stent boost shows proper expansion of the stent and good covering of the whole stenotic area. Next. The final result, March, by the Cypher stent, excellent result, and patient symptom free, and patient used to come regularly to me. Again, next one, 2007, after 2007, regularly used to come to me 3 to 4 times in a year, and November 2010, patient presenting on pain once again. So during the last annual CSI Calcutta, we select the case for the management restenosis case from BML. We have done it. The cipher shows the restenosis that time. Now what to do now? Whether give another drug-eluting stent, or it is the drug-eluting balloon, or bypass surgery. I intended to plan because other vessel, right coronary artery circumflex is good, ejection of 30%, but patient is very, very dysmech because of COPD and renal impairment, creatinine level that time 3.8. Ultimately, I take a decision, and Praveen with me that day did the workshop, so we have taken the decision, joint decision for better to be done by the drug-eluting balloon dia. Next. So first we dilated by the conventional balloon, sphincter. Then I use the cutting balloon. Cutting balloon, so entirely about 26 size length. So after good dilatation by the balloon, conventional balloon as well as by cutting balloon, then plan for the dia 3 into 26 millimeter.
The slide is not moving.
Yeah. Next. Yeah. Then next. Now it is, the dia is placed, but I try to avoid the just ostium because chance of restenosis may be more, try to avoid to it. So cover the entire length of the stenotic area, 3 into 26 dia. Next. Yeah, good coverage. Next. Proper expansion from the origin. Next. Yeah. Proper expansion of the whole proximal LAD from the ostium up to the end of the stenotic area. Next. Yeah. The good opening of this stenotic area. Next. So, good visualization shows the proper expansion of the whole. So, initially the vector stent and the cipher stent, then followed by the dia. So, we have placed the dia, inflation pressure 14 atmosphere pressure for 60 seconds. So, good result. Now, up to from December 2010 to even I seen the patient 7 days before, patient doing well. My plan to do the angio, but he is not agreed because doctor, I have not the chest pain while do this thing. So he's doing well, except some dyspnea because of the bronchial asthma. Now creatinine level now 2.8. So I am happy even 9 months clinical follow-up. So total the problem of the patients altogether 15 years. So take home message, if we do the clinical follow-up to be necessary after the interventions, we have to take our comorbid conditions, hypertension, diabetes, renal impairment, that should be keep in mind. Then judicial judgment for this, the procedure strategy, either balloon or an angioplasty or by CABG to be taken properly. Thank you very much.
Thank you very much. Thanks. That's a very good illustration of the use of DEB and an added option for us in these kind of cases. I just want to highlight the note that if you've used DEBs long enough, you have to change a bit on the paradigm of how you look at it. Acute angiographic results may not be as good as putting a stent. I think if there's good flow and not too bad of residual stenosis, leave it alone. You've seen on follow-up, they actually continue to remodel, actually gets better with time. I think that's what we need to understand.
So, my question arises, again there is the restenosis, what can be done? Because of present renal failure and present COPD, concomitant surgery, that is my problem. I'm thinking what to be done later on.
Lima to LAD.
He has to go for CABG.
Yeah.
It's very easy. Sometimes you don't even have that option.
Yeah.
Now, this case also again shows one more interesting point, that the bare metal coming back with restenosis after 11 years.
Yes.
Maybe common wisdom is that you escape 1 year, you are completely free of restenosis. That's not the case.
So actually, we conducted a restenosis study from Toronto. 26 countries of the world participated. From India, we contributed 98 cases. So that time, our restenosis rate of bare stent really only 12%. So that is our study. And what the drug-eluting stent, is nearly close to nearly 10%. So during long-term follow-up period of 10 years of that, the Toronto, our project study.
Yeah. Thank you very much, Dr. Panja, and thank you for all the speakers for an excellent presentation. I think with this, we'll close this session. Next.